Good evening, everyone, and welcome to CareEpilepsy Ethiopia's webinar series. My name is Dr. Salim Taye. I'm a clinical care and training lead at CareEpilepsy Ethiopia, and I'm honored to be hosting this session. At CareEpilepsy Ethiopia, we are committed to supporting individuals living with epilepsy, their families, and healthcare professionals. And we do this through education, advocacy, and improved access to care. These monthly webinars are an essential part of our mission. Today, we have an important session on pediatric epilepsy, and we'll see some topics about pediatric epilepsy, including its management, diagnosis, epilepsy syndrome diagnosis, and all. And I will introduce Annat Yaunatu, co-founder and CEO of CareEpilepsy Ethiopia, to introduce our speaker, Dr. Neal Sankhla.
Okay, thank you. Thank you, Dr. Salim, and good evening, everyone. It's a privilege for me to join you today. And as Dr. Salim said, for CareEpilepsy, we are committed to increasing knowledge about epilepsy, both in the community and among professionals. And these webinars are one of the tools that technology has given us that we use to invite and have the privilege of having people like Dr. Neal join and share his experiences and knowledge on epilepsy. And I'm sure it will be a very rewarding 1 hour that we spend with him. And just as an introduction, Dr. Neal is a pediatric neurologist at Children's Healthcare of Atlanta and serves as assistant professor of pediatrics at Emory University of Medicine. Sorry about that. He received his medical degree from Drexel University, his child neurology residence training at the University of Alabama in Birmingham, and his pediatric epilepsy fellowship training at the Children's Hospital of Philadelphia. So you can see that he's a very rounded person. And Dr. Neal, it's a privilege. Welcome to Addis Ababa. He's currently in Addis Ababa. And welcome to CareEpilepsy platform. And we do look forward to learning from you. Over to you.
Yeah, thank you so much for the kind introduction. Okay, let me share my screen.
Before we begin, a few quick notes. Please keep your microphones muted during the presentation and feel free to type any questions in the chat and we will address them during the Q&A session. And at the end of the session, we will provide details about certification for participants, but for certificate, you should be available until the end of the webinar. So please follow us attentively and be active. Thank you. You can start, Dr. Neal.
Okay, well, great. Well, thank you so much for this opportunity. So today we're going to talk about principles of managing pediatric epilepsy or pediatric seizures. So this is going to be a very practical kind of lecture where basically we're going to go through, if a patient comes into our clinic or comes into the hospital and they're a child and we think they have seizures, what are the questions that are going through our mind? Number one, are these seizures? Is this epilepsy? Okay, why do they have epilepsy? How should I treat this? If I've started a medicine and they're still having seizures, then what do I do? If I've started a medicine and they're not having seizures, what do I do? So we're going to kind of spend about 5 to 10 minutes on each of these questions. We're going to talk about some of the data that helps inform how we make these decisions so that you can kind of use this knowledge when you're seeing patients with epilepsy. All right, so the first is my patient having seizures? So they come into the office, they're having some type of a movement, some type of a behavior, and it's my job to figure out, could these be seizures? So a seizure is a sudden, uncontrolled burst of abnormal electrical activity in the brain, which can cause changes in behavior, movements, sensation, or consciousness. And so there are a lot of things that can mimic or that can look like epileptic seizures. And so there was one study of about 200 patients who came in to their first, with a concern for a first-time seizure. About 17% of them had what we call a seizure mimic or something else that looked like a seizure. So some of the common things we see, so the two most common mimics that we will see in patients coming in with concern for seizure, number one will be, we call psychogenic non-epileptic seizures. So these are episodes that can look very, very similar to epileptic seizures. They can have body shaking, they can have changes in awareness, they can have a lot of different types of movements that are involuntary, but rather than being caused by abnormal brain waves, these are caused by the body's response to underlying stress or anxiety. We're going to talk a little bit more about what that can look like. Syncope or fainting, again, something that can look very similar to seizures. And there's a very long list of things that can look like seizures, things like movement disorders, like tics, or sleep myoclonus, where people have twitching and sleep. Sleep disorders, migraine with aura can cause neurologic symptoms that can look like seizures. And infants, things like gastric reflux can cause kids to have a certain type of movement that can look like seizures, things like clonus, and many, many, many more. So I'm going to show you guys some different videos. So this is one of my favorite videos. So in Germany, in this one medical school, they did this experiment where they took some of their healthy medical students and they had them breathe very, very fast and then stand up very quickly and then faint or have a syncopal episode to see what kind of movements their bodies would do. And so I'm going to show you some different videos. So again, this is a healthy, medical student, and we're going to see he falls, and we can see there's some kind of intermittent twitches of all of his, extremities. Here's one video. Let me show you another video. Okay, here's another healthy medical student. She's had a syncopal or fainting episode, and we can see that her body is having, again, all these kind of jerking type of movements. Let me show you one more. This is another healthy patient with a syncopal episode, and we can see that their body is having all these kind of intermittent type of movements or jerks. And so, seeing the video, there are certain things that jump out to me as, okay, this doesn't look like a seizure. But now you have to think that if a patient comes into your clinic or, parents are bringing their child in, and what are they going to describe? They're going to describe, my child, passed out, their whole body was shaking and they were not responding. And just based on the description that they're giving you, it can sound a lot like seizure. This is a patient who has psychogenic non-epileptic seizures, which again are movements that can look a lot like epileptic seizures, but are caused by the body's response to underlying stress or anxiety. Again, we can see the body get stiff. There's some type of, shaking type of movements. Again, there's certain things that when I look at this video, the type of the movements, it looks different than an epileptic seizure, but just based on the description what family gives to you, it's going to sound a lot like an epileptic seizure. And then some seizures can look a lot of different ways, and some seizures can look very kind of bizarre. So this would be what we call a hypermotor seizure. There are some patients with focal epilepsy coming from their frontal lobes, and they can have seizures that are very, very bizarre, where they have these called hyperkinetic, or they have lots of kind of fast and kind of non-rhythmic kind of movements. And sometimes these can be seizures. Let me show you another video. This is another frontal lobe seizure. You can see this patient is just in bed. They're flailing their arms. And this is actually a type of seizure. So it can be difficult to sometimes tell the difference between a seizure mimic and a seizure. And so there are some different questions that when you're seeing a patient, you can ask to really help tease out those differences. And so number one, what was happening right before the event? And so, for the most part, epileptic seizures, they're unpredictable, meaning, they'll happen, without any kind of specific pattern, without any specific trigger. They'll be kind of, random when they happen. Now, some people with seizures, they just have seizures when they're asleep. Some people with seizures, might be triggered by flashing lights or, hyperventilation when they're breathing very heavy, or rarely some other types of things can trigger seizures. But most people with seizures will be kind of unpredictable. So if you ask this question and they say, well, right before the episode, I was, dehydrated, and then I stood up very quickly, and then I had this episode, well, then you might be thinking, okay, maybe this is more of a syncope, or, every time before this happens, my child, they're in the same class at school and they're having some bullying, and okay, well, maybe there's a stress component with psychogenic non-epileptic seizures. I typically ask, okay, was there some type of a warning or some type of an aura that they felt right, at the beginning of this? So again, right before the episode, if I felt lightheaded and I felt tunnel vision and then I passed out and had it, okay, again, I'm thinking more about syncope. Or if I felt, this pressure in my chest, and I was breathing very heavy, and I couldn't catch my breath, and my heart rate was increased. And okay, maybe now I'm thinking it sounds maybe like a panic attack. Maybe this is more kind of a psychogenic non-epileptic seizure. And then epileptic seizures themselves can present with a lot of different symptoms kind of right at the onset. So it can be a certain type of a sensation in the body. It can be a certain type of smell. It can be, a certain type of vision, like a visual thing that they're seeing. It can look a lot of different ways, and a lot of those things can overlap with things like migraines with aura. Okay, I want to ask, okay, did they lose consciousness? And if so, for how long? So for example, if it was, seizures can be anywhere from a couple seconds up to, a typical, seizure is less than a couple minutes, but sometimes seizures can be much longer. Sometimes they're 5 minutes or longer. If the episode lasted for like an hour or longer, very, very unusual for an epileptic seizure. If the episode was, maybe about 10, 15 seconds and sounds more like a syncopal episode, well, that kind of makes sense. If during the episode, they're fully aware, but they're having these, full body types of movements, it's very unusual. If you're having a seizure,
just be going through it and look at it.
If you're having a seizure involving your whole brain and you're having kind of, shaking movements of both sides of your body, you're typically unconscious. And so if you're aware, but you're having some kind of movements, then maybe that's more of a movement disorder. If during the episode, the family is interacting with the patient, and as they're talking to them, the movements kind of resolve. And then as they stop talking to them, the movements kind of pick up. Okay, maybe these movements are distractible or suppressible, kind of maybe more of a tic or a tremor. Another thing I'll always ask my patients is, well, show me what kind of movements, your body was doing, or tell parents, show me what kind of movements their body was doing. Because it's very hard for parents to describe, what they're seeing. They don't really have the vocabulary to say, okay, it was rhythmic, it was flexion, extension, it was, it was waxing and waning. This is not something that people are, very comfortable with doing. So it's very helpful to actually see the type of movement. So I'll ask patients or parents to kind of show me, was it, kind of flexion extension? Was it kind of side to side movements? And was each arm kind of moving individually? And these can give me a lot of clues as well. So typically with a convulsive seizure, you're going to see very kind of rhythmic flexion extension of your arms and legs, either both sides or on one side. Typically with, we saw some of those convulsive syncope episodes where the movements were kind of random and happening, in different extremities at different times. With psychogenic non-epileptic seizures as well, you're going to see a lot of these kind of bizarre kind of maybe side to side movements that require a lot of different coordination for muscles. It's very different than what we will commonly see with a convulsive seizure. You can ask, did they bite their tongue or have incontinence? Again, very common symptoms that we'll see with convulsive seizures. How do they feel afterwards? So a lot of people after a seizure can have, we call a post-ictal period, where they'll feel kind of more drowsy or more out of it for anywhere from a couple minutes to a couple hours. And then were they awake or asleep? So you're going to ask all these questions. And even after getting all these questions, sometimes you're still not 100% sure. Okay, maybe there's some things that sound like seizure, but then there are some things that maybe sound a little bit less like seizure. And so when you're really not sure, it's okay to wait and try to get more information. So a lot of times when patients and families, they come in to see me in clinic, the child may have had, a couple seizures, maybe it happened in school, maybe it happened with a different family member or at a friend's place. And so the parent has actually never seen it themselves. So now they're describing to me what, the teacher told someone else, who's told them, who's told me. And now the description is very, very kind of different maybe than what actually happened. And so, it's okay to say, okay, let's wait a couple months, see if it keeps happening, and then tell me what it looks like, rather than just jumping to, if I'm not kind of convinced based on the description, I don't want to just jump to make a diagnosis and put them on a medicine. During the episode, I'd say families should try to see if they can get the patient to come out of it. So typically, if you're having a seizure, it just has to run its course. There's nothing you can do to get it to stop. And so if a child is doing some type of movement, say they're kind of staring and they seem kind of unresponsive, I'll say, tap them, see if you can get them to snap out of it, give them a sternal rub, pinch their finger, see if they're actually, completely unaware, or if they're still kind of aware, but just not responding. If the family has a cell phone, you can ask them, if it happens again, get a 5 or 10-second video. If they show me a video, then, I can say pretty confidently, these are the types of movements that look like seizure, or this looks like something else. And then if after that you're still not sure, well, then you can consider starting a medicine and seeing if the episodes get better. But, that can sometimes get a little bit complicated. And so, so they've come in, they're having these episodes. Okay, I'm now convinced that they're having seizures. So now my next question is, well, what kind of seizures are they? And so we have different ways of classifying seizures. And so the first way of classifying them is based on, are they focal onset or generalized onset? So focal onset meaning coming from one part of the brain and then potentially spreading to different areas. This is going to cause symptoms and maybe in one part of the body that then maybe spread to other parts of the body. And we have seizures that are generalized onset, meaning right at the beginning of the seizure, involving the whole brain at once. And then sometimes we have unknown onset, or we're not so sure. Then we also classify it in terms of, if there's physical movements, we try to describe, what kinds of movements are we seeing? And we have different words that we use. We might say it's a myoclonic seizure, which is a very fast kind of involuntary muscle twitch that may last for a couple milliseconds. We might say it's a spasm, which is a kind of a quick jerk, but then you kind of pause for a second and then you kind of relax, and it may happen in clusters. We might say it's a clonic seizure, which are kind of rhythmic kind of body jerks in one part of the body or the whole body. We might say it's a tonic seizure where your body is just stiff. And then you can have an atonic seizure where you just kind of lose your tone and you pass out. So these are some of the different ways we classify the motor side. And then we can also classify things in terms of other types of symptoms. So they can be you can have a sensory seizure where you have some type of a feeling in some part of your body. You get some type of smell, some type of a vision. You can have changes in your behavior or your awareness. You can have emotional symptoms like fear. And so it's important to try to classify as best as you can the seizures, because if you can classify your seizures into focal and generalized onset, this will help you then figure out what type of epilepsy do they have, and then what type of seizure medicine is going to be the best for them. So I'm going to show you guys a couple of videos. So this is an example of a myoclonic seizure. So let me play that again. So again, it's very quick, involuntary, muscle twitch. I would say, this is in terms of, your choices are either focal or generalized. It looks like, it kind of involves both sides at the same time. So I'd say, looks like a generalized seizure. It's a quick kind of myoclonic seizure, involuntary muscle jerk lasting a couple milliseconds. Let's watch it one more time. Myoclonic seizure. Okay. This is what we call a myoclonic atonic seizure. So I want you to watch this video. And so let me pause. So what we see is the child is eating and they have a quick jerk. So a quick myoclonic jerk, arms come up, and then they lose their tone and they kind of pass out. And so it's a myoclonic and an atonic seizure. And it's important to try to characterize this because, this patient actually has an epilepsy syndrome, which is called epilepsy with myoclonic atonic seizures. So it's a specific epilepsy syndrome, which this is the characteristic seizure type. All right. So again, they've come in, they have episodes. I'm convinced that they're seizures. I think I know what kind of seizures they might be having, either focal or generalized, motor, non-motor. Now, my next question is, well, is this epilepsy? And so epilepsy, you can meet criteria for epilepsy in 3 different ways, but the most kind of common and useful way to meet criteria for epilepsy is someone that's had at least 2 unprovoked seizures occurring more than 24 hours apart. You can also meet criteria for epilepsy if you've had 1 unprovoked seizure and then a very high risk of more seizures, or you can meet criteria for epilepsy if you have an epilepsy syndrome. And so let's just focus on this first criteria. So at least 2 unprovoked seizures more than 24 hours apart. And so the first question is, well, it has to be an unprovoked seizure. So what are some causes of provoked seizures? And so there are a lot of things that can provoke a seizure. So there are certain electrolyte abnormalities. So if a patient comes in, they've had very, very severe diarrhea, well, maybe they have, low sodium and low magnesium, and that's provoked them to have a seizure. Maybe they have very severe vitamin D deficiency, and that's caused them to have low calcium levels, which has provoked their seizure. Maybe they've had a recent head injury, or they have a brain infection, or a brain bleed, or a brain tumor, or they've ingested some kind of toxin. These are all things that can provoke a seizure. But most of these, can be ruled out with a careful history and exam. That if you're seeing this patient in your clinic, they're otherwise well appearing, it's pretty unlikely that they have one of these causes that's provoking them to have seizures. So the most common cause of seizures in children is we call febrile seizures. We're not going to go into this too much in this talk, but basically a febrile seizure is something super common. It affects about 2 to 5% of kids, at some point in their childhood. So much, much more common than epilepsy. And these are going to be seizures that occur in the setting of a febrile illness in children between the ages of 6 months and 5 years. And, in order to meet criteria for febrile seizures, you can't have, one of these other provoking factors like an infection or electrolyte abnormality. And these are also not going to be kids who have a history of previous seizures without fever, who have a history of epilepsy. So this is going to be an otherwise healthy kid who has a fever, maybe they have a cold, and then they have a seizure. Again, very, very common. About 98% of them will outgrow their seizures, by the time they reach the age of 5 and do really well. All right. So again, they've come in, I'm convinced they're having seizures. They've had more than 2 seizures 24 hours apart that don't seem to be provoked. So now I think they have epilepsy. So my next question is, well, what kind of epilepsy is it? And so in terms of figuring this out, the first step is, figuring out your seizure type. So I think this is a focal seizure. It's caused shaking or stiffening in one part of the body, which then maybe progress to a full body seizure. If they're having focal seizures and just focal seizures, then it's a focal epilepsy. If they're having only generalized seizures, then it's a generalized epilepsy. If they're having both, then it can be a combined or a mixed type of epilepsy. And then sometimes we just don't know. If I can figure out their epilepsy type, then I'm trying to think about, well, what could be causing it? If it's a focal seizure, then I'm wondering, okay, is there some type of structural or infectious or immune cause that has kind of impacted the development of their brain or the structure of their brain that's put them at risk for having seizures from that particular area? If it's a generalized seizure, I might be thinking, okay, could there be some kind of genetic cause, getting a good family history? And then after that, the next question I'm having is, do they fit into an epilepsy syndrome? And so an epilepsy syndrome is, this characteristic combination of seizure types, age of onset, certain EEG patterns, developmental features, and certain types of genetic or structural causes. And so basically, if a large group of children will come in with seizures at the same age and the same type of seizures and the same type of story, then we group them into a syndrome. And we do that so that we can study those kids and figure out, what types of medicines might work best for them, and what, do they have lifelong seizures, or do they outgrow their seizures? Do they have other types of symptoms outside of seizures commonly? And then we can study those kids. And then when another child comes in with the same type of story, then we can take that information and apply it to the other child. And so this can help us figure out the right type of medicine. It can help us think about the prognosis of that type of epilepsy. And so about 1/3 of children with epilepsy will have an epilepsy syndrome. And so we're going to talk about some of the most common and important ones to know. So the 3 most common epilepsy syndromes by far are these top 3: self-limited epilepsy with central temporal spikes, also known as benign Rolandic epilepsy. Then there's childhood absence epilepsy and juvenile myoclonic epilepsy. So the 3 most common epilepsy syndromes we see in children. We're also going to talk about infantile spasms, which is just a very, very important one to always kind of know about and have in the back of your mind. All right, so self-limited epilepsy with centrotemporal spikes, also known as benign Rolandic epilepsy. This is the most common epilepsy syndrome we see in kids. About 15% of children with epilepsy have this epilepsy syndrome. And so the typical story we're going to see is, seizures maybe start around the age of 7. It can be earlier or later, around the age of 7 or 8. A very characteristic type of seizure that they happen out of sleep. They'll wake up with some type of a numbness on one side of their mouth. Then they'll have kind of a twitching of one side of their face, a lot of drooling. And then this can then progress sometimes to unilateral or one-sided shaking. And then that can sometimes progress to full body shaking and unresponsiveness. Has some very classic EEG findings. So it's in the name. So self-limited epilepsy with central temporal spikes. So if you do an EEG, you're going to expect to see central temporal spikes. With this type of epilepsy, we don't always have to treat it. We're going to talk a little bit more about that later. But if we do decide to treat it, carbamazepine is a really great choice. And in this name, we see self-limited. And so most of these children, about 95% of them are going to outgrow their seizures by the age of 12 and not have seizures when they get older. So let me show you, this is a kind of a classic video of the type of seizures we're going to see with this epilepsy syndrome. All right, so what we're seeing here is, she's having this kind of one-sided unilateral facial twitching. She's having this very prominent drooling. So very, very, very classic kind of video of what these seizures can look like. Okay, so the next epilepsy syndrome I'm going to talk about is childhood absence epilepsy. So this is the second most common epilepsy syndrome we see in children. About 10% of children with epilepsy will have childhood absence epilepsy. This is an epilepsy that, the typical story is going to be, starts in a child between 5 and 7 years old. Can be a little bit earlier or later, but typically at 5 to 7 years old, they have a very characteristic type of seizure in which they'll have the sudden onset, behavioral arrest. They'll kind of pause, they'll stare off. They will be sort of unresponsive, and they might have a little bit of eyelid flutter or a little bit of kind of involuntary type of movements in their hands or their mouth. Typically will last about 10 seconds, after which they'll just kind of completely return back to normal. And these can happen very, very frequently, like 20 to 50 times per day, sometimes, over 100 times per day. Has very, very classic EEG findings. 3 hertz generalized spike and wave is the word you might see in an EEG report. And the nice thing about this type of epilepsy is this is a diagnosis that you can easily make in the clinic, because you can actually trigger them to have a seizure. And so with 3 minutes of hyperventilation, having them breathe kind of quickly, oftentimes I'll put a piece of paper or a tissue in front of them, and I'll just ask them to put it in front and just ask them to kind of keep blowing, like I'll time it for 3 minutes. With hyperventilation, you can trigger a typical seizure about 90% of the time. So you can make your diagnosis immediately. And in these patients, valproic acid is a really great choice. And about 70% of these patients will outgrow their seizures by the time they become an adult. And so here's a really typical video. So this is it looks like about a 5-year-old, and she was blowing on the pinwheel, and then she has this pause, a little bit of kind of eye flutter, a little bit of mouth movements initially. She's not responding as the EEG take a stock in her, and now she snapped out of it, and now she's responding. Let's watch that one more time. So seizure starts right now. She's paused. Again, she's unresponsive, a little bit of eye flutter. All right, the next epilepsy syndrome I want to talk about is juvenile myoclonic epilepsy. So this makes up about 10% of children with epilepsy. This is the most common epilepsy syndrome that we're going to see in adolescents or in that sort of teenage age group. Has 3 very characteristic type of seizures. The most characteristic is myoclonic seizures. Again, these very quick involuntary muscle twitches. Happens frequently when they wake up from sleep. They're also going to have generalized tonic-clonic full body shaking seizures about 90% of the time, and then sometimes they also have absence seizures, like the one we saw in the previous video. A JME is typically a lifelong disorder. So for most kids, we can get their seizures under control with medicine. But if we try to come off of medicine, a lot of times, most of the time, they'll, again, start having seizures. So it's one that, valproic acid is a great choice. And we typically, once we get their seizures under control, we typically won't try to come off of medicine. All right, so let's watch that again. So this is a teenager, has a very quick kind of involuntary myoclonic jerk of her body. Very, very quick, couple milliseconds, and she has a diagnosis of JME. All right, and the last epilepsy syndrome that we're going to talk about is infantile spasms. And so infantile spasms, this is the most common epilepsy syndrome that we're going to see in infancy. So this peak onset is somewhere between 3 to 12 months of age, and has this sort of triad of 3 kind of typical findings. Number 1, a very, very characteristic type of seizure called infantile spasms. So it can look a lot of different ways, and we're going to look at some videos, but it's typically this very quick kind of flexion or quick extension. Then they're going to pause for a second, and then they're going to relax. And then it's going to happen in clusters every 10 to 30 seconds, often for a couple minutes, 5 minutes, 10 minutes, most commonly when they're waking up or when they're falling asleep. So again, quick movement, then they relax, happens in clusters. They have this very, very characteristic EEG finding called hypsarrhythmia. I'm just going to show you a picture of it. We're not going to talk too much about EEG in this talk, but I'm going to show you a picture of it because it's really important. They're also going to have a developmental regression. And so a typical story that you might hear is, a 6-month-old, they've come into your clinic, family has noticed that, they were meeting their milestones. Okay, they were rolling over. Maybe they were starting to sit up on their own. They were babbling. They were sleeping throughout the night. They were a pretty happy kid. And now all of a sudden they've seen a big change. They're not rolling over anymore. They are, always irritable. They're not sleeping well. They're not progressing in the same way they were. So they've had this kind of decline in their development. Then they start having this very typical kind of seizure. It's commonly seen in children with a history of structural brain abnormalities, so kids with, birth trauma who have had this hypoxic injury to their brain, or kids who are born very prematurely who have had some type of intraventricular hemorrhage, or kids with stroke, or other types of, structural brain abnormalities. And then there are a lot of genes that we know about that can also cause this. So this is a really important one to keep in your back of mind because, if we hear the story, this is something that we want to diagnose and treat as quickly as possible. So, with other types of seizures, I mentioned, okay, it's okay to kind of wait and make sure that, we're convinced it's seizure, and then you can start a medicine. But with infantile spasms, this is kind of an emergency because the longer they go having these types of seizures, having this developmental regression, having this EEG finding, the worse that their developmental outcome and the worse that their epilepsy will end up being long-term. And so we really want to treat this as soon as possible. The way we treat these type of seizures is different than other types of seizures. So the 3 first-line medications are ACTH, prednisolone, and vigabatrin. And let me show you some videos. So you can see this quick kind of extension type of spasm. This is a little bit more like kind of a flexor spasm, so very quick kind of movement. Another kind of extensor spasm. Sometimes they can be really subtle, like just kind of this head drop, and then we're going to see it's going to happen again. So it happens in a cluster. So as you can see, these can be really hard to diagnose because babies and infants, they do lots of kind of funny type of movements, and maybe with reflux they do certain kind of movements like this. Maybe just when you startle them, they have some certain kind of movements like this, and so sometimes it can be kind of difficult to feel really confident about this diagnosis. And so an EEG in this specific situation, if you're able to get it, can be really, really helpful because they have this very, very characteristic type of EEG finding. And so this for reference, and we're not going to go too much into EEG, but I just want you to this is a normal EEG in a 4-month-old child. So we can kind of just get a glimpse of what this looks like. And this is a patient with hypsarrhythmia. So, completely different. EEG has become very, very high amplitude. It's become very chaotic. If we look at it more closely, we can see there's lots of little spikes in there. So their EEG is just completely changed. And as a response to this, they're not developing, they're not sleeping well, they're irritable all the time. And the longer that this EEG pattern is there, the worse their developmental outcome is going to be. All right. And so again, I'm convinced the patients come in, I'm convinced they're having seizures. I think I know what kind of seizures they are. I think they meet criteria for epilepsy. I think I know what kind of epilepsy they have. So the next question is, well, how should I treat them? And so the first question for you guys, and I want to give you guys a couple seconds to think about it. Why do we treat seizures? Just take a moment to kind of think about it. A lot of reasons, but just think about, why do we actually treat seizures? And so these are some of the answers that I kind of came up with. So seizures are disruptive. So say I was having a lot of seizures, it would, I wouldn't be able to drive. It would make it harder to do my job. It might make it harder to care for my family. Seizures can, be disruptive and keep you from, living your life the way you want to live it. We treat seizures to try to prevent physical injuries. So people during their seizures can fall and injure themselves. We treat seizures to prevent brain injury. So certain types of seizures, typically very long seizures, can cause irreversible brain damage. It takes, for full body seizures, it takes about 30 minutes of continuous seizures to cause irreversible brain injury. For a focal seizure, kind of maybe one part of the body, it takes about 60 minutes of continuous seizure activity to cause irreversible brain injury. But we want to avoid that. There's a stigma to treating seizures. And this is something that I know CareEpilepsy is working hard on in terms of helping provide education about what epilepsy actually is. But there's a big stigma to patients having seizures. There's a lot of comorbidities or a lot of other symptoms that people with uncontrolled seizures will have. Things like anxiety, depression, ADHD, learning disorders, a lot of other symptoms that go along with having uncontrolled seizures. In general, most kids will outgrow their seizures at some point before they become an adult, and treating their seizures or being able to get their seizures under control is going to improve the chances of them ultimately outgrowing their seizures. And another reason is that we want to try to prevent, this finding called SUDEP, which stands for sudden unexplained death in epilepsy. So something that we sometimes see, especially in children and adults who have this long-standing history of epilepsy, especially in children and adults who are having generalized tonic-clonic or generalized tonic seizures, especially in children and adults who are having seizures in sleep, is that sometimes they can just pass away unexpectedly without a clear cause. And so in terms of stigma, so there actually have been some nice studies done in Ethiopia looking at the effects of stigma and comorbidities. And so this was an article published, I believe in 2023, where they found that in Ethiopia, about 52% of people had an unfavorable attitude towards people with epilepsy. So another recent article, I think came out last year, where they found that in Ethiopia, the prevalence of depression amongst patients with epilepsy was found to be about 42%. This is a little bit higher than what we see in the US, and some of this is probably related to this very kind of high rate of stigma. And so again, so they have seizures, they have epilepsy. I think I know what kind of epilepsy they have. I want to treat it. So now the question is, well, which medicine should I pick? And as I understand it, these are the typical options that we'll have available in Addis or in Ethiopia. So valproic acid, phenobarbital, carbamazepine, phenytoin, diazepam, and then possibly lamotrigine or levetiracetam sometimes. And so, depending on their type of epilepsy, that can kind of help guide us in terms of which medicine we should pick. So if it's a generalized epilepsy, typically valproic acid is going to be a really good kind of first choice. And if that doesn't work, potentially phenobarbital or diazepam are going to be good choices. For the generalized epilepsy, we typically want to avoid what we call our sodium channel medicines like carbamazepine or phenytoin, because sometimes, those medicines can make seizures worse in patients with generalized epilepsy. If the patient has focal epilepsy, pretty much any of these options are going to be good options. If you have a neonate with epilepsy, typically phenobarbital is going to be our go-to medicine. All right, so you've picked a medicine. What are the chances that the seizures are going to stop now that you started them on a medicine? And so say you have 100 patients who come into your clinic with seizures. You have 100 patients with focal seizures in your clinic. You start all of them on valproic acid. About 50% of them will become seizure-free. So now you have 50 patients who are still having seizures despite trying valproic acid, maybe increasing the dose. So now you pick your second medicine. Now say you start them on carbamazepine. Of those 50 patients who are still having seizures, 13 of them will become seizure-free. So now we have 37 patients left who are still having seizures. Now you pick a third medicine. Say you pick phenytoin. Now, by the time you get to your third medicine, only about 4% of patients will become seizure-free. So now we have about, 37 minus 4. We have 33 patients out of our 100 who are still having seizures on their third medicine. And then as we kind of go down the list, trying more medicines, now the chances of becoming seizure-free after you've gotten to your third or fourth or fifth medicine now becomes very, very, very low. And, this is kind of the case, in Ethiopia, we have kind of this list of medicines. In my practice in the US, we have more than 30 different seizure medicines available. But despite having so many kind of new medicines, our actual ability to control epilepsy hasn't really changed over the last 40, 50 years. And so, these numbers of about, 1/3 of patients becoming medically refractory or having seizures that are not responding to medicine, this is true regardless of, if you're using the valproic acid and carbamazepine and phenytoin, or if you're using some of the other medicines that, I might have available in the US. The main difference is, okay, some of those newer medicines might have better side effect profiles, but the ability to control seizures is pretty much the same with those medicines and the medicines that we have in Ethiopia. And so, ultimately, okay, you might want to pick your medicines partly based on the type of epilepsy they have, but then the most important question is, well, what medicine can they actually get? And so there was this nice study done, published last year in Addis, where they found that of these 357 patients with epilepsy, about 55% of them were able to adhere to their seizure medication regimen. And what they found is that 61% of those patients had difficulty accessing their medicine or affording their medicine. And patients with better access to their seizure medicine were twice as likely to actually take their medicine. And so picking a medicine that they can afford, that they can access, super duper important. All right, so again, we've confirmed, okay, they're having seizures, they have epilepsy. I think I know what kind of epilepsy. I've picked a medicine based on the type of epilepsy I think they have, and they're still having seizures. And so this is going to be very common. So, only about 20% of the time do we have the situation where a patient comes with seizures, we start a medicine, and then they just never have a seizure again. Pretty uncommon. Most of the time, they're still going to be having some seizures. And so what do we do in that situation? So we typically, when we pick a medicine, again, patient comes in with focal seizures, start them on a starting dose of valproic acid. They're still having seizures. I'm going to titrate that up until we either reach a maximum dose based on their size and weight, or until they develop some type of a problematic side effect. So maybe it's affected their behavior significantly. It's affected, if we're able to check their labs, it's affected their liver enzymes and other types of things. And so now we've increased our valproic acid. Say the valproic acid was helpful and we were able to tolerate it, but we're still having seizures. Well, then I'm going to add on a second medicine. So maybe I'll add on a carbamazepine. Say I added on valproic, so I started on valproic acid, and as I increased it, it really wasn't helpful or it really wasn't tolerated. Well, now instead of adding on a medicine and keeping valproic acid, I'm going to add on carbamazepine and then come off of valproic acid. And then we're going to keep following that same kind of process with additional medicines. And then really kind of after we get to our second medicine, this is when I really kind of start to discuss with family that it's very likely that trying a third, fourth, fifth medicine, very likely that this child is going to be medically refractory, because that's just what we know about how children respond to seizure medication. And so in those situations where I have a child who is, they've tried a couple seizure medications, they're still having seizures, I'm going to go back to this initial question of, why do we treat seizures? There are certain situations in which I'm going to really push to try a third or fourth or fifth medicine. There are certain situations where I'm going to say, okay, maybe let's just take a step back and we kind of keep an eye on it. And so I want you to imagine that we have a patient that comes into our clinic who has, had this, birth trauma. They've had this hypoxic injury to their brain. They have severe developmental delay. Maybe they have severe cerebral palsy. They are not able to kind of walk independently. They have, again, this kind of severe developmental delay. And imagine that they're having kind of brief, maybe 10-second focal seizures about once a day. Now I'm kind of going through this list in my mind of, are these seizures disruptive? Well, the seizures are very short, they're very focal, the patient's may be very delayed. And so, for this patient, they might not actually be that disruptive to this, child's quality of life. There are some kids who they have a seizure and then they'll be out of it for a couple of hours and really drowsy. And then there's some patients who they'll have a brief seizure and they'll be right back to their normal. And so I have to think about, okay, are these seizures disrupting this child's quality of life? We treat seizures to prevent physical injury. So this child is non-ambulatory. The chances of maybe them having a physical injury is probably pretty low. If the seizures are pretty short, well, it might not be affecting, might not be putting them at high risk of brain injury. If the child is very, very, cognitively delayed, well, stigma might not be something that, they're able to comprehend, or that is something that's impacting their quality of life. And so, for some children, we might not have a very, very strong reason to keep trying different medicines if the seizures themselves are not strongly impacting their quality of life or putting them at high risk for any of these types of things. And so, for example, in a patient who's having those 10-second seizures once a day, well, there are 86,000 seconds in one day. And if 10 of those seconds they're having a seizure, the other 86,000 they're not having a seizure. And with any medicine I pick, there's going to be maybe a 20 to 30% chance of having side effects. And those side effects will affect those 86,000 seconds, not just And so you really want to think about, is what I'm doing the right thing for this patient? Not just they're having seizures, let's just keep pushing different seizure medications. Okay, now, best case scenario, we've started a medicine, they've become seizure free. Well, now what do I do? Do I keep them on medicine forever? When do I try to come off of seizure medicine? And so the good news is that about more than half of children with epilepsy will eventually outgrow their seizures before they become an adult. And so a general kind of rule of thumb is, if a patient has been seizure free, they've not had any seizures for 2 years, that's a good time to kind of consider, do they still need to be on this medicine? Have they outgrown their epilepsy? We picked these 2 years just from, we've done some studies on, if we wait for 1 year, then they have a higher chance of having seizure relapse if you come off of medicine. If we wait for 3, 4, 5 years, the chances of having seizure relapse is about the same. And so as if you wait for 2 years. So really, 2 years without any seizures when you want to really kind of reevaluate. If they have an epilepsy syndrome, say they have this self-limited epilepsy with centrotemporal spikes, well, then we can, instead of just kind of going by these general numbers, now we can actually look at that syndrome and see, okay, do kids with that epilepsy syndrome, do they outgrow their seizures or not? So if they have self-limited epilepsy with centrotemporal spikes, well, we know that about 95% of kids will outgrow their seizures by the age of 12. And so we can use that as a guideline to be a little bit more specific to that patient. With JME, juvenile myoclonic epilepsy, we know that although patients can become seizure-free on medicine, they typically require lifelong medication, because we know that when we come off of medicine, they typically will start having seizures again. All right, so the last thing we'll talk about is, when should I get an EEG? So I know an EEG is not always very easy to get. It can be resource intensive. And so there are just kind of a handful of situations in which I think it's really, really helpful to get an EEG. And so, I spend about 40% of my time, my clinical time, reading EEG. It's something that, I'm really passionate about, something I really enjoy. But we, tend to get a lot of unnecessary EEGs because people don't always know when an EEG is going to be helpful or not. One situation which is very helpful is when we're worried about infantile spasms. So we saw those videos where, those children were doing these kind of movements, and, it can be very hard to figure out, is this infantile spasm? Is this reflux? Is this startle? Is this shuddering spell? Is this something else? And so again, with infantile spasms, they have this very, very characteristic EEG finding. And so that can help us figure out very quickly, what are we dealing with? An EEG can be really helpful when we're not sure if someone's having seizures or if it's a mimic. So in general, if a patient has epilepsy or has seizures, and we do a 30-minute EEG, about 50% of the time, we're going to see some abnormal brain waves that show that they're at high risk for seizures. If we're able to get them to fall asleep during their EEG, that sensitivity increases to about 80%. That if they're able to fall asleep, about 80% of the time, we're going to see some of these characteristic abnormal brain waves that show that they're at high risk for seizures. So that can help us make a diagnosis when we're not sure if someone's having seizures or something else. An EEG can be really helpful when you need to figure out if they're having focal versus generalized epilepsy to pick their medicine. So in general, a lot of times we're not sure what kind of epilepsy a patient's having. Sometimes, generalized seizures can involve, full body shaking with unresponsiveness or some other type of full body type of symptoms. Focal seizures sometimes can start in one area of the brain and then quickly spread to the whole brain and look very similar, involving whole body shaking or whole body stiffening. It can be really hard just from the description sometimes to figure out, Are we convinced that this is a focal epilepsy, or is this, for sure a generalized epilepsy? And so if we're not sure, a lot of times we'll use a broad spectrum medicine. So medicines like valproic acid, phenobarbital, diazepam, these work for all kinds of seizures, as opposed to carbamazepine and phenytoin, which are really kind of good for focal onset seizures. So if you're not sure, we can use a broad spectrum seizure medicine, but say we really want to figure it out to guide our medicine, an EEG can be helpful in that situation. Say they have a generalized epilepsy and they haven't had a seizure for 2 years, you're thinking about coming off of medicine. Well, sometimes an EEG can be helpful to see if those abnormal brain waves have cleared up, to see if, they're going to be, very likely to be successful coming off of seizure medicine. And the last situation an EEG can be really helpful is, say you have a patient that comes into your hospital and maybe they've had some seizures, maybe you've given them a dose of diazepam, maybe you've given them some IV phenytoin, and they are just completely altered. It's a couple hours later, they're not waking up the way that you would expect someone to wake up after having received these medicines. Sometimes what we see is that patients can have subclinical seizures, meaning seizures that we see on their EEG, seizures that we see with their brainwaves, but seizures that are not having any outward physical manifestations. So seizures that can just cause children to be altered or unresponsive. In that situation, EEG can be really helpful. All right, so in summary, so there are a lot of things that can look like seizures. And so, you want to ask some of these different questions to try to feel really confident about, are we definitely dealing with seizures, or could this be something else? If you can figure out the type of seizure that they're having, or if you can try to characterize it, this is going to help you characterize what type of epilepsy they have. About a third of children with epilepsy fit into an epilepsy syndrome. And then if you can fit a patient into an epilepsy type based on the type of seizures, or an epilepsy syndrome based on their story, this will help you pick your treatment. In general, for patients with a generalized epilepsy or an epilepsy that involves their whole brain right at the onset, you want to avoid medicines like carbamazepine or phenytoin because that can make your seizures worse. About a third of children with epilepsy will remain medically refractory despite trying 3, 4, 5 different medications. But most children will eventually outgrow their seizures. And so after 2 years without any seizures, this is when you should really think about coming off of medicine. And so thank you again for this opportunity. So Emory, has had this partnership with Addis Ababa University for the last 15 years. And so a lot of my colleagues and have had the opportunity to come here and learn from the expertise of, the folks here in Addis and also do a little bit of teaching. And I'm really excited. I'm going to be here for another week, and I'm really, really excited to meet the teams and to see how I can help and what I can learn. And so I think we have a couple more minutes. Let me see what questions people have. All right, so I see some questions in the chat. First one is, what was the average duration of treatment? So do you remember which slide that was from? That's from Haley Merriam.
Yes, thank you so much for this extensive and very informative lecture or delivery. It was about when do you stop, the anti-epileptic drugs. But you answered it, if they are free for 2 years. I asked that question before you delivered that one. So thank you so much.
That's perfect. Then Dr. Tesfaye asked, which medication should be discontinued first in case of 2 or more seizure drugs started? And so typically I will just ask parents very clearly, which of these medicines do you feel like has helped? Which of these medicines causing side effects? And then, I'll just, whichever medicine hasn't, family feels like hasn't helped or is causing side effects, I'll typically come off of that medication first. How to taper seizure medicines for patients taking more than 2 seizure medications. So, typically we want to wean medications over the course of about 4 to 6 weeks, kind of gradually week by week. Once we come off of a seizure medication, those first 6 months off of a seizure medication are when we're at the highest risk for having breakthrough seizures. And so, say we were to do a very, very long taper, 6 months or 9 months, well, now they're at high risk during those 6 or 9 months, they're also at very high risk for those following 6 months. And so typically kind of a reasonably short taper, like 4 to 6 weeks, will, allow you to, have the shortest period of time in which they're at very high risk for having breakthrough seizures. Can children with epilepsy become insane? So a lot of children with epilepsy can have comorbidities that can affect their learning, their memory, their behavior. And so, super important to, try to get their seizures under control. But it is something that, children with epilepsy have very, very high rates of those kinds of, psychiatric or learning kind of comorbidities. Can an EEG be carried on a neonate of a few days old presenting with twitching? Absolutely. And so we do, in my practice, we do a lot of EEGs on neonates. We do, at any age. So if they're born at 24 weeks gestation and they're having episodes, and we'll put EEG electrodes. We typically, typical EEG uses 19 electrodes on the scalp in a certain configuration. For neonates, their head is very tiny. You can't fit 19 electrodes. So they have a kind of a condensed type of map of where we put the electrodes. I believe they have 12 electrodes, if I remember correctly. And so absolutely, neonatal EEGs can be really challenging to read, but it can be really, really helpful. Which patients need EEG indications? I think we covered that right at the end, but that's a good question. When is EEG a call for concern when one presents with seizures? And can we use EEG to screen for purpose of seizure disorder? So yeah, these are good questions. So let's see. When is EEG a call for concern when one presents with seizures? So I think we kind of talked about those things. Do either Nigek or Tsigi, do you have any kind of specific, if you want to clarify those questions, if you feel like we didn't talk about that enough in our talk? In terms of the question of can we use EEG for screening purposes for seizure disorders? So, yeah, absolutely. And so, in terms of epilepsy syndromes, a lot of them will have very, very characteristic EEG findings. In patients with seizure disorder, about 80% of them will have some, abnormal brain waves that show that they're at high risk if we are able to, get them to fall asleep. The challenging part is that, a lot of kids, say you have a child who's had this, birth trauma and they have this, brain injury. A lot of them are just going to have abnormal EEGs just related to their, the way that their brain is formed and developed and the injury to their brain. And so an EEG in itself has to be kind of taken in the context of the patient. In a subclinical seizure on EEG after 2 years, seizure-free period, how do you proceed? And so it's a good question. That's a tough question. And so, subclinical seizures, it's something that oftentimes we will see, in patients who are, getting prolonged EEG. So in my practice, a lot of children who are in the hospital, we'll put them on EEG for long periods to try to screen for seizures. And so, that's, a little bit less common in Ethiopia that, we'll put children on. It's more of kind of like a 30 to 60 minute kind of EEG. So it may be kind of difficult to identify subclinical seizures, but in general, I think the best thing you can do is repeat an EEG for 30 to 60 minutes, try to see if you can get them to fall asleep, and then kind of use your best judgment. Oh, perfect. Okay, so the question is, how do we differentiate a seizure from epilepsy? Perfect. So, a seizure is, just this, again, this abnormal electrical activity. It can cause, some type of physical symptoms or some type of, symptoms in the body. That can be caused by a lot of different things. So say, you have a, say I had a stroke and I have some type of, injury to one part of my brain that can cause me to have seizures, right after having a stroke. So, that is not epilepsy. That's just, I have something that's going on. It's causing me to have some seizures. Or say I I went out and I drank a lot of alcohol and it caused me to have a seizure. Well, I don't necessarily have epilepsy. I just have had a situation that has kind of provoked me to have a seizure. Epilepsy is basically, patients that, have had multiple seizures and are at very high risk for having more seizures. And so that's the difference. But any way I can, does that make sense, or can I clarify that anymore? Okay. Well, good. Well, again, thank you guys for this opportunity. If you guys have any follow-up questions, feel free to, Inad has my contact information. Feel free to reach out to her and she can give you my email address. I'm always happy to touch base if you have any specific patients that you're wondering about, or any follow-up questions.
All right. Right, Dr. Neal Sankhla, thank you so much for your time. And it's such a privilege also to have our own pediatrician, Dr. Ayale and Dr. Maskaram, joining us at this webinar. Well, I hope you all have learned and found this a very useful teaching model. If I could kindly ask for everyone who is willing to put their video on so we can take a picture of our attendees, and then we will let you know next month we'll come up with another exciting topic. And I also want to thank CareEpilepsy team for organizing this meeting, this webinar. And thank you all, and keep in touch, and we will pass on the information. And also CareEpilepsy is always here to support you in any possible way. Thank you so much and have a lovely weekend. Let me just take a picture. Okay. I think I've managed to get it now. All right.
Okay.
All right. Thank you, everyone. Thanks a lot. Bye-bye.
Everyone, before you leave, can you please put your full name on the chat box for attendance purposes? Because most of your names are in abbreviations and we couldn't identify who you were. So please put your name in the chat box before you leave. Thank you.
Thank you. And also, please note for the next time that we only supply attendance certificate for those who've stayed from the beginning to the end. So we do keep record of that. And unless you've attended the whole hour, you will not be issued an attendance certificate. Thank you so much.